Thank you very much. I have no conflict related to this talk. I think the last case by Andre showing you all the different techniques to get reentry really summarized my talk. So this is just a recap if you missed something. But I like to show this talk through a case, and we can talk through it so you see what is our mindset when we talk about reentry. So it's an 87-year-old with coronary disease, hypertension, diabetes mellitus, and CKD, has had a prior TMA. Unfortunately, the patient has had dehiscence of his TMA and is not healing. So this was a case that the patient also had multiple prior operation on the right groin. So we didn't want to come in the up and over technique. So we decided in this situation to come from the radial approach. So this is a radial approach using some of the Trumo long sheets. So in this situation, we came down and you can see that the iliac system looks good. The proximal SFA looks good. So we placed the Trumo 150 centimeter destination sheet in from the radial approach all the way to the proximal SFA. We then started working through some of the longer length devices. So using the Metacross balloon, which is a very long balloon, is a RX system, and you can basically advance it to about 180 centimeters. So using that as a support, since we had the sheet in the proximal SFA, using the balloon as a support and a stiff angle glide wire, we were able to cross the mid SFA and the proximal popliteal occlusion all the way to the P2 segment. So you can see here, we are in the P2 segment now, and we have crossed the SFA and the POP in these areas doing angioplasty and getting to this area. Once we got to this area, we now have a second layer of occlusions. We have the popliteal occlusion that you can see, but there is also this occlusion from the posterior tibial artery. In this situation is what we're calling now the radial to pedal approach. So we got the pedal approach now, so we came from the PT. So we're getting retrograde PT access using fluoroscopy in this situation. We have a glide gold, as you can see here. This is a exchange length glide gold. And we are able to come off the PT. And now we come off the PT, come through the popliteal, and we get to this region. Now we have a wire coming from the radial approach that is sitting in a subintimal space in an antegrade. We have a wire glide gold coming from the retrograde approach from the pedal PT in the subintimal space here. And there's a bunch of collaterals that are coming off here, one of the challenges in the antegrade approach. So the question is that what do you do in this situation now? And this is the talk basically on reentry. So typically we try with wires first. You know, I'm pushing the wire, trying to see somehow I can make the wires meet, and keep going back and forth. It's not like I do one thing for 10 minutes. As you saw with Andre, you know, you push the top wire, you come back, you do the retrograde wire, you keep doing that, and after a couple of minutes you realize, okay, this is not gonna work. Now you move to the other approaches, so doing the cart and the reverse cart. So these are the carts, this is the reverse cart, and this is a cart technique. So bringing the balloon from the top, inflating it, bringing the balloon, and the key to this is using the right size balloon. So if you use a 3 millimeter balloon, it's not gonna work. If you're in the popliteal and the SFA, you need a 5 to 6 millimeter balloon. I would say 4 to 5 usually should do the job. So once we have done the cart and the reverse cart and it still is not working, we do what we call the parallel balloon technique. So we have one balloon coming from here to here, that's coming from the top, from the radial approach, and we have the other balloon coming from the PT, and we try to have the shoulders meet. And we are hoping by inflating these two 4 millimeter balloons, we are able to create a little dissection plane that we can then pass our wire through. And as Andre was describing, usually we like to advance the retrograde wire up like this I'm trying to do. But as you can see, despite doing the cart, reverse cart, parallel balloon, my wire keeps going to subintimal space. And this is one of the challenges, that if when you try too hard, you create these subintimal spaces and now you're stuck. Your wire keeps going to the same place. And this is a schematic picture of this, which I showed in my previous presentation. Again, the cart technique, doing a balloon in the retrograde approach, the reverse cart in the antegrade approach. You're doing the parallel balloon, trying to have the shoulders kind of create a dissection flap so you can get through, and then the facilitated reentry that we talked about. There's also obviously the reentry devices that you're familiar with, the Pioneer, the Outback, and the Interior that you can use. But usually using these cheaper devices, you can get crossed, honestly, 95% of the time, 98% of the time. So in this situation, because the cart, and we have that strategy, that's our strategy. Try with the wire. If it doesn't work, go to the cart. If it doesn't work, reverse cart. If it doesn't work, parallel balloon. If it doesn't work, we go to the facilitated reentry. Remember, we are doing this in a radial approach. So since the PT was a large vessel, we brought the balloon down from the radial approach. So this is a 5 by 120 balloon from the radial approach. And this is the outback coming here from the posterior tibial. We are able to now cross into the balloon, as you can see here, using the facilitated reentry. And now we are pulling the balloon back all the way through the SFA into the radial sheet and externalizing. So now we have an externalized wire from the radial approach all the way to the PT, the radial to pedal approach. Now we can treat from the PT. It's a large artery, and we can do whatever we want to do, exactly what PK is trying to do in this case. He's trying to treat from the DP. And we are able to balloon now. As you can see, we did a compliant balloon angioplasty with a 5-0 and a 6-0. We then did DCB treatment of the SFA and the popliteal artery. And then we moved to the superized stenting of the popliteal segment, knowing that we have created multiple dissections and that we need to put a stent there. But we first gave the drug, and now we're going to scaffold the popliteal artery to make sure that we have a good lumen to treat these patients' TMA that has dehisced. And this is basically our final result. So you can see that the popliteal artery now is open. It looks fantastic. You can see that the PT looks great. And one of the things that I don't like just treating from the pedal approach is exactly what Steven said, is that you need to take a final angiogram to make sure that you have a good runoff to the foot. And the challenge when you're doing only from the pedal approach is that that is very difficult to do, especially if you have a 5 French, 6 French sheet. So in this situation, since we had the radial approach and we have a big sheet sitting in the distal SFA, we are able to remove our devices from the PT. We are holding a gauze with a little handle here, with a little forceps, so that our hands don't get radiated. And we can take an angiogram. You see the access site looks beautiful. You see that the PT is gorgeous. And we now have a beautiful inline flow. So we were able to fix the patient's SFA, popliteal, and PT via the radial to pedal approach. And hopefully his TMA will heal. Thank you very much.